Hi everybody, welcome. My name is Lauren Roberts. I'm a senior biology pre-med major here at Robert Morris University. And my senior thesis was procalcitonin and its possibility as a future biomarker for predicting bacterial infections in patients and how it could be used in guiding antibiotic therapy in those patients. So first, what is procalcitonin? Procalcitonin is a precursor for the hormone calcitonin, which is produced on the calc1 gene of chromosome 11. It's 116 amino acids long, and its other hormones that are produced along with it are CGRP1, adrenomedulin, and amylin. Now, calcitonin, the purpose of calcitonin is that it is used to reduce the levels of calcium in the bloodstream during hypercalcemia, and it's produced in the C cells and the K cells of the thyroid gland. Now, procalcitonin does not share this responsibility in the body. It's actually unknown what it does, but we do know that it plays a large role in the inflammatory cascade response. And it's produced all over the body rather than just the thyroid gland. So that's in parenchymal tissue, differentiated cell types such as liver, kidneys, and adipocytes. So we classify procalcitonin as a homokine because it is both a hormone and a cytokine. So hormones have a general responsibility with a particular system within the body, and cytokines have a more targeted and local effect. Procalcitonin acts as both. So the procalcitonin relationship with bacterial infections that we have found so far is that it increases in the bloodstream up to several thousand-fold during the presence of bacterial infection. We have found that it fluctuates in the bloodstream as the level of infection fluctuates. So this would be helpful because as the severity of the infection increases, so should the level of procalcitonin. And as it decreases, we found that the procalcitonin level will also decrease. This will be useful in diagnosing techniques later on, and this will also help guide our antibiotic therapy. In the labs, we have taken macrophages and stimulated them with endotoxins produced by bacteria as well as raw bacteria. And in response, the procalcitonin has been produced within 3 to 4 hours. This is significant because within 3 to 4 hours of bacterial infection, we would be able to take a procalcitonin level from that patient and get a reading within 1 hour after. So bacterial infections versus viral infections. Viral infections produce interferon gamma. Interferon gamma stops the production of procalcitonin in the body. So this was significant because we would not be able to measure procalcitonin in the bloodstream if there is a viral infection, but if there is a bacterial infection, we would. So we would be able to differentiate between the two of them. Future problems would arise if there was a double infection, but that's to be studied further. Problems with antibiotics today. So this is going to be the main focus for my research here. Superbugs. So you guys have probably seen on TV a lot. Superbugs are resistant to antibiotics. And this has been caused from the overuse of antibiotics and the lack of finishing prescriptions. So if it's a 10-day prescription, people are stopping at day 7. The bugs, a few of the bugs will live on, and they'll carry a resistant gene with them. This is a problem because we can't treat those with your regular everyday antibiotics. We have to come up with stronger antibiotics, and it's becoming a real problem in the medical society today. Lower respiratory tract infections can be both viral and bacterial. A large group of them are bacterial though. And in 2004, it's recorded that 10% worldwide that 10% of worldwide morbidity rate was due to lower respiratory tract infections alone. So this was quite significant. Bacterial infections are also a major cause of morbidity around the world, but we have to keep in mind that this includes third world countries that do not have the same access to healthcare that we do. So. Bacteremia, which is defined as any kind of bacteria that's found in the bloodstream. This can be a key predictor to morbidity rates in ICU settings. So if we can find the bacteremia by measuring the procalcitonin level, this could be very helpful. Also, antibiotics, like people take them all the time, so they forget that they have allergic reactions with the patients. So the less you prescribe antibiotics, the more you reduce that. Also, antibiotics are not cheap, they are expensive, so if they're not needed to treat that patient, we shouldn't have to prescribe them. And then, using more science and determining biomarkers such as procalcitonin, hopefully we can reduce this. So how is procalcitonin measured? Currently, there's 2 accepted measurement tools. They're both developed in Germany by the Braun Corporation. First was the Lumi assay. This assay had a lower limit detection of 0.5 micrograms per liter, and the newer one, the Cryptor assay, has a detection of 0.06 micrograms per liter, so that's a significant improvement there. And with those improvements, we've been able to determine more exact levels for different diseases and what they mean in the body. There's been quite a few studies around the world. A lot of them have actually been overseas, especially if they involve human patients. In the US, we have done a hamster trial. And basically this study, we had 2,000 male hamsters, and one group was given regular pellets, that was the control group, regular food pellets to eat, and then the other one was given food pellets that were infected with E. coli. The E. coli patients, or hamsters I should say, showed significant increases in their procalcitonin level. Human studies included the one that happened in France in 2003, and this study was able to determine that there is a limit of 0.5 micrograms per liter that indicated bacterial infection. So anything higher was bacterial infection, anything lower they were unsure at that point. But this was, once again, it was in 2013, so it was used with the Lumi assay at this point. In Switzerland, we had 243 patients. This included both males and females. And it was divided into 2 groups again, a control group that was treated normally and a second group that was treated using the procalcitonin guidelines. So the procalcitonin guidelines patients did have a significant reduction in the number of antibiotics that were used, as well as the cost of the antibiotics, but they did not have any significant increases in morbidity or additional diseases. So these were actually the guidelines that were used by this study and the other study. So anything less than 0.1 micrograms per liter of procalcitonin indicates the absence of bacterial infection. Here, we really believe that bacterial infection is not present in the body at this moment, and it's either some other kind of infection or a reaction in the body. So here, we would really discourage the use of antibiotics. Between 0.1 and 0.25 micrograms per liter, it's very unlikely that there's bacterial infection. There's a possibility that there was one prior to the test and that it's healing. So we would discourage it, but there has been cases where there is still bacterial infection. Serum levels between 0.25 and 0.5. This is when you start to really see the bacterial infection being present in the body. And then greater than 0.5, that's a significant bacterial infection. We strongly suggest using antibiotics. So gaps in research that I found was because obviously this is a developing test, we need to continue to make more specific measurements for procalcitonin in the body and correlate them with the diseases so that we know more specifically how to treat those. Also, we need to find a way to differentiate between patients that have bacterial and viral, if there's a specific level, and also my thesis was, does procalcitonin testing help to determine whether or not antibiotics should be started in patients with infectious bacterial disease? If so, these levels could help determine antibiotic therapy. My methods, I collected my data from Cross Hospital, and this was a retrospective study, so these patients have already been treated, and I collected the data from there. So I analyzed it using Excel, and this is my results. I found that 45% followed the guidelines. So 45% of the doctors did treat patients according to the guidelines listed below. So that means that if it was less than 0.25, they did not use antibiotics, and then if it was above 0.25, they were using antibiotics. Now, I extrapolated out those that did not follow the antibiotic therapy, and I have it listed as 41% were less than 0.1, and more than, or 40% were greater than 0.1. So within those groups, this means that those that were less than 0.1 should not have received antibiotics, and they did. And those that were greater than 0.1, you could lie within two categories. You could lie between the 0.1 and the 0.25 mark, which means it was highly unlikely but possible, and they still prescribed antibiotics. Or you could be greater than 0.1, and they should have been prescribing antibiotics, but they didn't. Now, I only found that on 2 occasions, but it was included. I did find this interesting and a problem. In the US, we practice empirical therapy a lot, so lots of times antibiotics will be prescribed when the patient comes in is presenting with symptoms of an infection, and just be on the safe side until results come back and you start to give antibiotics. That is fine, but for the sake of this study, it did skew my data a little bit, because if the antibiotics were prescribed prior to the procalcitonin test, it would have lowered the levels already. This is my culture results in comparison to the procalcitonin levels. What I wanted you to get from this graph was that the procalcitonin level and the culture results make sense up into the 0.5, and then there is an increase in the positive culture results, which would mean that there is a bacterial infection. However, there is a small differential between positive and negative culture results, meaning that culture results may not be the best way to determine if there's bacterial infection. And then lastly, my last graph is, this is showing the number of patients that received antibiotic treatment and did not per calcitonin level. And what's significant here is the number of patients that actually received antibiotic treatment with the low procalcitonin levels. So from this study, I've gathered that we need to find more specific ways to diagnose patients with bacterial infections and to prescribe antibiotic therapy in the U.S. to limit the number of antibiotics that are used. And although my data was skewed a little bit because it is not necessarily my data that I created, but I just collected data from other doctors. If I was to do another trial, I would, or study I should say, I would create it like the trial in Switzerland and have a control group and an experimental group that followed the procalcitonin guided therapy. Thank you very much.